Okay, so moving on to talk about cognitive function. During this section, I want you to keep these two people in mind. So this is just a case study I want you to have in the back of your mind as I go through this. So a new small group fitness studio in Salt Lake City offers a 45-minute performance circuit class, similar to something like a CrossFit or an F45 class. If you're not familiar with what that is, that might be some type of hybrid or combined training, meaning you're doing some resistance training exercises, but you're typically doing them circuit style, meaning there's not a lot of break time between them. So we're probably improving some aerobic capacity, improving some muscular fitness as well. So something like a 10-minute dynamic warm-up, 30 minutes of circuit alternating compound resistance movements. Things that might be examples of that are things like a squat, a bench press, an overhead press, a push-up of some kind, right? So, and looking at moderates to heavy loads, 6 to 12 repetitions, and aerobic intervals at 60 to 80% of your heart rate reserve. So there we're looking at a vigorous intensity aerobic exercise. Uh, and then 10 minutes of functional core balance work and a cool down. Okay, so we've got a 50-minute workout. So we've got two then different members. We've got Jim, 62-year-old, has exercised regularly for decades, strength trains twice a week, hikes or cross-country skis on the weekends, and has good cardiorespiratory fitness. Okay. Then we've also got Taylor, a 22-year-old who works a sedentary office job, has low cardiorespiratory fitness, and is new to structured exercise. Both complete the program 3 times per week for 6 months. Okay. So we've got Jim and we've got Taylor, and these two individuals are completing this uh, exercise program. Okay. And I want you to think about what effects can they expect cognitively from this program? So first, we start with the paradigm that physical activity leads to some type of physiologic adaptation that then improves a health outcome. Okay, so we're typically saying exercise is the exposure, then some adaptation is essentially my mediator variable, and then I got improved health outcome. Okay. So some of the things that might look like, right, that we've already talked about are, right, physical activity might decrease blood pressure. It might decrease waist circumference or HbA1c. It decreases the risk of various diseases, increases strength and lean mass, right? Some of these things that it does improve mental health, right? We can see increased endorphins and serotonin, improved mood, decreased anxiety and depression, improved self-esteem. We also see for cognitive function, things like increases in BDNF, increases in memory and attention and executive function, decreased dementia risk, right? And improved learning and brain plasticity. So this is, I don't expect you to have this memorized. As we go through, we'll cover some of this more in depth. But I just wanted you to see in physical health, mental health, and cognitive function, how we have physical activity resulting in some type of adaptation that then improves whatever health outcome I'm interested in. And this is, I know I've shown figures similar to this in the past, but I feel like it is worth repeating and maybe putting it into the context of what we're going to study. But we've got, right, some exposure variable. A mediator is on the causal pathway, meaning my exposure affects my mediator, which then affects my outcome. We've got confounder variables that are going to affect both the exposure and the outcome. We've also got moderator variables, which affect the strength of the relationship between the exposure and the outcome, but that isn't on the causal pathway. Okay, so the mediator is on the causal pathway. The moderator is not. It's just affecting the strength of the relationship between the exposure and the outcome. And then we have covariates, which are other variables directly related to the outcome. Okay, and I'll give you a little bit more clear picture of this, but I just wanted to review what these variables mean before we jump in. So first, when looking at cognitive function, this is a massive topic, and this slide is really intended to help give us some idea for what the scope of this topic is. So cognitive function, we could be talking about two things. One, we could be talking about fluid intelligence, or we could talk about crystallized intelligence. So fluid intelligence is essentially my ability to learn and manipulate information. Crystallized intelligence is my ability to use previously learned or recall previously learned information. Okay. So you've got these two very large categories under cognitive function. Then under fluid intelligence, we also have these subdomains. So I've listed them here for you, but you have attention, processing speed, executive function, learning and memory, language, visuospatial function, and social cognition. Okay, so we've got also, what is that, 7, I think, subcategories under cognitive function, which had already 2 subcategories. Okay, executive function is bolded because it's one of the ones that we are going to focus on throughout this lecture. So I wanted to highlight that here. But inside executive function is really looking at like goal-directed behavior. What's my ability to focus on a specific objective? But there are 4 subdomains of executive function. So we have inhibition, working memory, switching, and then planning. Okay, so 4 subdomains in executive function. And those are all tested in different ways. So the Stroop test is one that we're going to do in class together this week that measures inhibition. The NBAC test is measuring working memory. And aerobic physical activity has been shown to improve the NBAC accuracy and reaction time. So we've got 4 different subdomains of executive function that are all measured in different ways. And then even within one way, the NBAC way, we could look at NBAC scores measuring accuracy of the NBAC or reaction time of the NBAC test. And I'll give you an example of what that is in the next slide. So that gives you some context for how huge this topic area is, right? And this is also one topic inside of an epidemiology course, inside of a kinesiology course, right? So we are not going to cover this in insane depth. I'm going to give you some useful information, but just know this is its own massive, massive field with all of these subfields as well. I also put the brain picture up here just to give you an idea of what we're going to really focus on. So much of cognitive function comes down to the hippocampus, okay, which is this yellow piece. And we specifically focus on the dentate gyrus, which is a portion of the hippocampus where we typically see response to physical activity. So we do see with aerobic physical activity increases in hippocampal volume as well as dentate gyrus volume, and we see increases in BDNF, and I'll show you some of that data in a moment. But I will say some things that then are going to affect cognitive function scores are age, physical activity intensity, test type, right? So how am I choosing to measure that? And then actually in most studies, we don't see an effect of blinding. So blinding would say, right, that the participants are not aware of the intervention, essentially. So it's often used in drug trials to say, hey, you don't know if you're taking a placebo or if you're getting the actual intervention. In basically any kind of physical activity intervention, it's really difficult to blind subjects to whether or not they're getting the intervention because they know that they're not being active. So these are examples of cognitive function tests. So this this picture demonstrates the Stroop test. So if I read these words down here, market, kid, scarf, kid, block, grab, pretty easy to read, right? Now, if I try to say the colors of the letters as opposed to the words, green, blue, red, orange, yellow, pink, maybe a tiny bit slower, but still pretty quick, pretty easy to follow. What's more difficult is when our brain is having to cross different neuronal circuits. And I say that because I don't actually know the appropriate terminology to use there. So now if I ask you to say the color of the letter, your brain is having to fight a little bit harder because it reads the word purple, but it sees the color green. And I've asked you to say the color green as opposed to saying purple. Okay. So we typically see decreased time or increased time rather to complete this as opposed to complete something like this. Okay. So that's what the Stroop test measures. And in the Stroop test, you would say the color of the letter. So I would say green, blue, red, orange, yellow, pink. Okay. And we're going to do that in class together and do a little intervention with it. This is the NBAC test, or a representation of the NBAC test. So what the NBAC test does is it presents some kind of a sequence, and it says, okay, you have to tell me if I say EA, and then I put an E here again, and you have to identify, hey, has E already shown up in the pattern? So this would be a 1 NBAC test. So you have to go back 1 in order to remember the E. Now, if I go ESSE, now I'm having to go 2 backwards to remember that an E had already shown up. Okay, so this is a visual representation of an NBAC test. And then lastly, we have spatial memory tests. So things that might look at, okay, can you remember that in the first square, you had a dot right in the middle? And then by the time that you get to the fourth square, were any of the previous 3 squares similar to the fourth square? So is it a match or not a match? Okay, so in any case, these are just basic examples that are relatively easy for you to understand, and they all measure different areas, right? So when we come back to here, Stroop is measuring inhibition for executive function. The NBAC is measuring working memory, okay? And then I don't even know what my visuospatial test, I think that was actually measuring visuospatial function, so a different domain. But right, you can see that inside executive function, we have 2 different tests measuring 2 different things. And you could actually have, in terms of measuring inhibition, which is that subdomain of executive function, we could have a bunch of different tests that do that. Stroop is just one example of a test that is trying to measure the inhibition aspect of executive function. Okay. Okay, so given that background, now I want you to have some type of a discussion around, if you saw the headline, physical activity drastically improves cognitive function, what are appropriate follow-up questions to that? What's your response to seeing that headline, to hearing somebody say that, yeah, running drastically improves cognitive function? What are the follow-up questions there? Okay. And I'm hoping that we're getting better and better at this as the semester goes on. And I'm interested to see what we come up with on perusal there. Okay. So moving on from cognitive domains, we want to look at incidence, prevalence, distribution, and cost of different cognitive health outcomes. Okay. So I included 2 here. So first we have dementia. So for dementia, I wanted to look at Alzheimer's disease because dementia is sort of this broad umbrella term, and Alzheimer's disease is a specific disease underneath the umbrella term dementia, but it accounts for 60 to 80% of dementia cases, and it is the 7th leading cause of death in the US. Okay. It's diagnosed, typically we start with some type of mild cognitive impairment, and you'll see that term in the literature, which is just referring to deficits in cognitive function that don't impact daily living. Okay. Once you see that your cognitive function is slipping enough that it's affecting your daily living, then we would typically see some type of a referral to a healthcare provider who will then perform cognitive testing to measure declines in memory, vision or spatial issues, decreases in problem solving, or issues with counting or language. That's often accompanied with someone close to you providing a health history. And occasionally, so especially if you have like a primary care doctor, they might be able to do some of this initial testing to see if they should then refer you to, let's say, a neurologist for further testing. And a neurologist might do things like look at specific biomarkers or brain scans. So in our case, we might look at, especially for dementia, things like beta amyloid and tau buildup, which are protein buildups in the brain, or things like shrinking hippocampus. Okay. The prevalence of now I'm forgetting if I looked up Alzheimer's or dementia specific statistics here. That's bad on me. I'm pretty sure this is Alzheimer's specific because I wanted to focus on Alzheimer's for this lecture. Prevalence of Alzheimer's in the US is about 6.7 million adults, which is about 4% of the US population over the age of or 4% of the US population. It's typically in adults uh, over the age of 65. And that number is expected to double by 2060. Looking at incidence, the incidence, I just thought this was really striking, which is why I wanted to include it. In adults 65 to 69 is 2.8 per thousand person years. And in adults older than 90, it's 56 per thousand person years. So the relative risk for that age change is 21, which is a wildly high increase in risk, right? So we know that Alzheimer's is significantly related to aging, right? This is a chronic disease. It's not likely going to be diagnosed early on in life. So we have a lot of opportunity for intervention, right? Chronic disease allows a lot of time for potential lifestyle intervention, especially. And some of the reason that this may be important is that deaths did increase 140% from 2000 to 2021, Alzheimer's related to deaths specifically. And we see a pretty stable death rates in other diseases. So things like cardiovascular disease hasn't, the death rates haven't drastically shifted in the same way that Alzheimer's related deaths have. Some risk factors that may be playing into this are things like genetics. So the ApoE4 allele specifically. Looking at twin studies, especially, it suggests that Alzheimer's is about 50 to 70% heritable. Now, that still leaves 50 to or 30 to 50% as not heritable. So there's a lot that we can do with 30 to 50%, but there is a significant genetic component to it, particularly if it's early onset Alzheimer's, which I think technically has to have been diagnosed before the age of 60 to be considered early onset, which is also associated with some specific genes. The risk also is greater in women compared to men. So when we write overall prevalence is about 4% of the US population. However, if we look at women and men separately, in women, it's about 5% of women, and in men, it's only about 2%. Keep that in mind, right? We talked about Taylor and Jim. Is that his name? Sorry, let's go back and find out so that I can jog my own memory. Yep, Jim and Taylor, right? Remember, we are trying to think about those two as we go through. So, risk is greater in women. Lifestyle or inactivity is a risk factor, especially blood pressure comes up a lot, age especially, right? We already talked about that. Education and socioeconomic status. So map here on the right is showing, similar to what you've seen with other research, that distribution isn't even across different geographic areas. We see definitely hotspots, although we don't see quite the same like really heavy hotspot down here in the southeast. Now it does look like there's increased prevalence here, but it's not nearly the effect size that we saw in some of the other chronic diseases like type 2 diabetes, cardiovascular disease, and obesity that we've looked at this semester. So, like I said, about 4% of the population. However, right, as age increases, that prevalence increases dramatically. So, in 85 and older individuals, prevalence is 13%. Okay, so that's pretty high. I think that's something like 1 in 9, 1 in 8 individuals has Alzheimer's. Oh, sorry, this is dementia, not Alzheimer's. My bad. You also see increased prevalence with lower education and with generally with lower socioeconomic status, but you can see that there's a little bit of flexibility here. Or sorry, I lied. This is flipped in my head. We see higher prevalence in higher socioeconomic status individuals. In my mind, this is the result of access to healthcare. You have greater access to healthcare with greater funds, and so you're more likely to be diagnosed with higher socioeconomic status. I think that's right. I may have to go back and edit myself on this. Okay, we do see differences amongst race as well, especially where we talked about blood pressure being a risk factor, right? We saw that there was much greater prevalence of high blood pressure in Native American and Black populations, okay? So we see something really similar here, which shouldn't be super surprising. but that in terms of the percentage of cases, we see greater prevalence among Native Americans and non-Hispanic Black individuals, and actually in Latino individuals compared with non-Hispanic white and Asian individuals, with non-Hispanic white individuals having the lowest risk. This has changed in incidence over time. So we do see an increased incidence, right? We see increased incidence of death, of Alzheimer's related deaths as well. Like I said, from 2000 to 2021. Okay, that's dementia for you. Then I also wanted to look at ADHD and autism, mostly because I had a student specifically bring up autism or ADHD. So I thought I'd include both because they're both related to cognitive function. Now, autism we've already had come up once this semester, but so these numbers should look really familiar, but about 1.7 million people have been diagnosed with autism in the US, which is about 2.8% of the population. And that's based on 2020 data. We have seen a 22% increase from 2018 and a 98% increase from 2010. Risk is higher in boys. In WHO says that it's approximately 1 in 100 children worldwide, so about 1%, so a little bit lower than what we see in the US population. But it varies widely by region. And we talked about how there are some reasons why we would expect to see that, particularly in the US, and why we would expect to see a difference in the US versus with global estimates, right? You have to have access to care to be diagnosed with autism. So we did see one changes in diagnostic criteria. So the DSM-4 started including autism, Asperger's, and PDD-NOS as one diagnosis as opposed to multiple. So it became autism spectrum disorder as opposed to three separate diseases. We also see the American Academy of Pediatrics started recommending screenings, which in about 2007, which didn't get widely implemented until about 2014, right? And so we would expect then for prevalence to increase. We have seen it stabilize in the last like 3 to 4 years, but there was a pretty drastic increase between 2000 to 2022 or to 2020. For ADHD, prevalence is about 15.5 million, so 6% of US adults and 7% of US children. What's really interesting with ADHD that I didn't know until I prepped for this presentation as a request from a student, but is that half of those were diagnosed in adulthood. So, right, a lot of children are not actually diagnosed. They're not diagnosed until they're adults, and especially with diagnostic criteria changing, were they diagnosed according to prior criteria or new criteria, right? It's a sort of a big issue, and it makes it difficult for researchers to know, okay, are we using old criteria, new criteria? Should we get everyone retested because maybe they were screened, but ultimately, like they were screened according to criteria that have changed. So maybe now they do qualify for assistance, for example, or maybe they do need some type of medication or intervention to assist with cognitive function. What was sad to me was that a third of adults and children are untreated, and 71% had difficulty filling their prescription because medication was unavailable. So even if you are diagnosed, unfortunately, access to treatment is still relatively low. So what's then the cost associated with those things? So for dementia, per person costs, these are some wild stats, by the way. Medicare payments are 3 times higher, and Medicaid payments are 22 times higher for individuals with Alzheimer's disease compared to those without. Uh, I did a little bit of digging. Medicare, right, is insurance for individuals greater than or equal to the age of 65. Medicaid is typically for individuals who can't afford care on their own. But what's interesting is that Medicare doesn't cover long-term facility. So you can't bill Medicare for staying on hospice, for example, or in a community home. You can bill Medicaid for that, though. And so there's crossover, right? So older adults often are getting both Medicare and Medicaid, but Medicaid is paying for the long-term facility, which has significantly higher cost. Okay. So I was just curious about like, why is there this massive difference? Um, In total 2024 spending, right? It's important to think about, yeah, healthcare for sure, right? Things like falls that might be the result of dementia, um, placing things in the wrong spot that then can ruin those things, right? You place your cell phone in the freezer, you misplace your keys, which then causes you not to make it to work on time, right? Things like that. So yeah, we have healthcare and we have lost productivity, but we also have long-term care facilities, hospice services, and those are associated with about a $360 billion price tag. And then additionally, you have unpaid caregiving, which accounts for another 350 billion, right? So often people who have cognitive function decrements require additional care, and that additional care comes at the expense of someone working. Okay. So very expensive disease. ADHD and autism. So it's really hard to get good numbers on this, by the way. So you can look at some of the citations that I gave in the slide notes, but lifetime costs for autism look like there's something between 1.5 and 3 million per person, or 35 to 60K annually. And if you think about, like, I think the median household income, meaning sometimes that's actually two incomes, is something like $70,000 in the US. So, right, without significant insurance help of some kind or federal help of some kind, that's that's more than half of your income. Um, Total US costs are estimated anywhere from 250 to 450 billion. So this is a massive, massive range. And it's really difficult, right? Because autism spectrum disorder it's on a spectrum. It does include three different diseases, all of which require different care, different levels of care, right? And because autism happens on a spectrum, some individuals require a lot of care, whereas other individuals can be pretty autonomous. So it's really difficult to get super accurate estimates there, but it's a very expensive disease typically uh, to to treat. ADHD, lower costs here, but these are also were estimated based on in 2012 was the only numbers I could find for ADHD, with national costs somewhere between 150 essentially and 250 billion. So just reaching the low end of estimated autism costs. So autism is the more expensive disease, despite the fact that prevalence is much lower. Uh, if you do convert that to 2012 dollars, right, because this estimate was based on 2024 data, then we're looking at 190 to 350 billion. So definitely hitting the low end of that autism cost in this case. Uh, Most costs are incurred by adults for ADHD. With 105 to 194 billion associated with adult costs, and that's based on these 2012 numbers, compared with children and adolescents at 38 to 72 billion. Okay. This was also just a really cool figure, which is why I included it. You can take a look at it yourselves. Outer rings are the high end of the estimate, and then inner rings are the low end of the estimate. And then it breaks it down by, right, where are those costs coming from? So anyway, just pretty interesting, I thought. But mostly we're looking at productivity costs as to why adults with ADHD or adult ADHD costs so much money. Okay. So we've got, right, two diseases, well, three diseases here. We've got dementia, really focused on the Alzheimer's piece of dementia. We've got ADHD and autism and the costs associated with those. So what's then the effect of physical activity on these disease states? So with physical activity, we do see increased neurogenesis, angiogenesis, and synaptic plasticity. So the risk and incidence of dementia and ADHD is substantially greater in individuals who exercise less than 3 times per week than it is for those who exercise more frequently. And this was this study had about a 6-year follow-up, and the hazard ratio was 0.62. You should be able to interpret that for me at this point in the semester. And that was adjusted for age and sex, right? Important variables to control for, given what we've just covered in terms of prevalence. This is pretty consistent across studies, with greater effects seen for Alzheimer's disease as compared to general dementia or Parkinson's disease, right? So I didn't cover Parkinson's disease or other dementia diseases, but it does differ across disease types. So again, it just adds some complexity to data analysis, right? When we're thinking that, okay, we've got cognitive function that we're interested in as essentially maybe my mediator variable, right? but then I've got cognitive function and how that then is associated with my outcome or disease state if I'm interested in the disease state. Now, I will say cognitive function could be my outcome that I'm interested in as well. So that would change your analysis. But in any case, the domain of cognitive function that I'm measuring really matters. And we saw how complicated that is with those wide 7 domains. And then inside executive function, we had 4 subdomains. So anyway, it gets really, really tough to statistically analyze well here. But in any case, when we look at systematic reviews and meta-analyses, we typically see greater effects. So physical activity has a greater effect at reducing the risk of Alzheimer's disease when compared with other diseases. Dose, though, isn't super clear, although I will present some data on that. Looking at Alzheimer's disease, I did want to highlight that there is some overlap in what we've already covered, right? So we see that aging affects cardiovascular disease, vascular dysfunction, and maybe Alzheimer's pathophysiology. We also see that exercise, right, is going to affect cardiovascular disease, and vascular function as well, and then have direct effects on cognitive function. So the effect of exercise and aging, or the combined effects of exercise and aging, are pretty complex and go through some of these other pathways, other disease pathways. So there is overlap between diseases we've already covered and covering cognitive diseases. This is some pretty interesting research that looked at the number of Alzheimer's disease cases that could be prevented with a 10 to 25% reduction in physical inactivity. It looked at a bunch of different variables, actually, but I focused in on physical inactivity, right, because it's physical activity epidemiology. And what we see is that if we could reduce physical inactivity by 10%, you would eliminate something like 100,000 Alzheimer's disease cases in the US population. If we could reduce it by 25%, that number goes up to 250,000. Okay, so physical activity is having a significant impact. And in fact, it was the variable in this study that had the greatest impact on Alzheimer's disease cases in the US. Okay, last slide, and then I'll give you a little break. Looking at physical activity and ADHD specifically. So I didn't cover this for autism again because ADHD was a student request. I can, right? I do try to respond to what you want to learn. In any case, effect sizes, which we're going to cover a little bit later. Effect sizes look at Hedges G or Cohen's D are the 2 most common. And to interpret those, anywhere 0.2 is considered like a small effect, 0.5 about a moderate effect, and 0.8 is a large effect. So, but effect sizes ranged from 0.18 to 0.77 in favor of physical activity improving cognitive performance, but you can see that that ranges from a small to moderate effect, with the greatest effects being seen on attention and executive function, right? Those are those subdomains of cognitive function. And then within executive function, specifically inhibition and impulsivity were the most likely to show improvement. So looking at some specifics, aerobic exercise had a moderate to large effect on attention, right? That 0.84, on hyperactivity, impulsivity, and anxiety and executive function. And you can look at those magnitudes as well. There were really heterogeneous effects and small sample sizes, but it still looks like aerobic activity is more effective than yoga, and that study compared those 2 interventions head to head. When looking at executive function specifically, right, we had larger effect sizes looking at inhibitory control. This is a massive effect size, by the way. 1.3 is huge. So it looks like there's really strong potential there, especially for the effect of aerobic exercise on executive function. What I found really interesting, though, is they looked at open and closed structured activities, and they found that both were really effective. So open structure would be things like recess, right? I'm not telling children what to do. I'm not telling an individual what to do. I'm saying, hey, this is open play, essentially, versus something that's really structured like a physical education program. And both seem to be effective, with neither being more effective. There was a study that said that physical activity was similarly efficacious to drug therapy without the side effects that can come from drug therapy, and without increased dropout rates. So a couple of really important things to note here is, one, They did not do a head-to-head comparison. So I don't know how they were justifying making that comment. So be really careful when you see, even in a peer-reviewed research article, things like that, statements like that. They presented no data that showed the effect that drugs have on cognitive function in individuals with ADHD, but then said that physical activity was just as good. That's a really strong statement to make without directly providing that evidence. And then, but what I found really cool and interesting was that there weren't increased dropout rates. So if you compared, often we say that drug therapy is, you're more likely to adhere to that. It's easier to take a drug than it is to engage in physical activity intervention. A drug takes me half a second to take a pill, a shot, whatever I need, right? A physical activity intervention has a lot of other barriers. There's lots of like time, money, knowledge, social support barriers to engaging in a physical activity intervention. So, but amongst kids, it looks like those are similar. Again, they didn't really provide super strong data to support that statement, but I thought it was a really cool idea, which is why I've included it here. And you can go dive into that research article further if you want. More research has been performed in children, but similar findings do exist for adults. But in that literature, they didn't cover dropout rates. And I would expect that dropout rates would be much higher for adults than it would be for children for obvious reasons, right? Things like work, family responsibilities, social responsibilities. So I wouldn't be surprised by that. Prescription recommendations are limited because the research in this area is pretty limited, but in their interventions, there was anywhere from 1 to 90-minute interventions, with the most popular being a 30-minute intervention, but not necessarily the most effective. That was just the most common. It does look like moderate to vigorous physical activity is more effective than light physical activity for treating symptoms associated with ADHD. Okay, so that would be things like that impulsivity and that anxiety and improving executive function. Okay, I'll give you a little break and then we'll jump into impacts on physiology.